Okay, the session's being recorded now, and I'll pass it over to our resident pre-hospital life support attendee. Go for it, Jamie.
Brilliant. Thank you very much, Dr. Nevin. Hello, everybody. Great to see you again. I realise it's been a couple of weeks break. Some new faces here as well, which is always fantastic to see. Welcome to session 5 of pre-hospital life support. It will be our penultimate session together. So the next session will be the last one. Until next time, we've got some exciting plans for some potential other series as well. So we're doing that. But yeah, today, 2 hours, it does sound like a long time, but I promise you, we've got some high octane turbocharged revision. We're going to be doing some awesome stuff, looking at life-saving interventions. We've got our friend Vianney here again, because we've been doing all sorts of use and abuse on her, him, whatever. And we've got loads of techniques that we're going to be learning together as well. So I'll just share my screen. Nav, could you just enable screen sharing?
Of course I can. My apologies. There we go.
Cheers. Thank you. So just share my screen, bear with me. Can you see that all right?
Yeah, all good.
Brilliant. So the overall topic of today's session, we're going to be looking at equipment. So I've already introduced you to most of the stuff that pre-hospital medics use. So we'll be looking at some other bits as well. We'll be looking at brains. We'll be finishing that off. So some more neurological first aid, which I love. It's awesome. And we're going to be looking at medical conditions. Okay. So thank you very much for everybody who's been submitting their reflective workbooks. So I've read all of them and marked all of them. Again, some really good comments and reflections in there as well. So keep them coming. For those guys who are just joining the series now, all of the recordings are available on the Medifine page, and all of the reflective workbooks are scattered throughout the chat as well. So you can just as easily catch up. But as always, because we're throwing a lot of information at you, at any point if you have any questions outside of the sessions, feel free to message me or send an email to Medifine, and we can certainly accommodate those questions. Okay, so before we dive into the Mentimeter reflections, the questions from last session, does anybody have any questions from the last session that they want to address before we dive into a Mentimeter? No? Lovely job. Right, let's see if this Mentimeter works. Can everybody see that? Is that all right? Cool. All right. Well, let's dive in with our first question then. So for those of you who haven't done Mentimeter before, just go to the top of the screen, type in that website on your phone or whatever, and type in that code, and you should be able to join this session. And the first question is from the burns session. You remember when we're assessing burns, we have to look at several things about the burn. And this is summarized in our acronym MADE, low shock. So MADE, low and shock. So 6 things that we need to look at when we're assessing burns. So see if you can remember any of those. And your comment should pop up on the screen. So we'll see. We'll see how many people remember it. Yes, good. Got location areas extent. Good, good, good. Got any more that people want to add to that? Mechanism burn, yeah. Mechanism, oh good, yeah. Different types of burn as well. Shock, airways, fantastic. Very well done, yeah. So, yeah, depth of burn as well. So this is our acronym that we use when we're assessing different types of burn and scald. And this neatly summarizes the different things that we have to look at. So the M is mechanism, and that just means how did they come to the burn? So was it electrical, was it chemical, scald, cold burn, so on. A is the next thing we look at, and that's airways. So are the airways compromised? So if they've been pulled out of burning building, the smoke might burn their airway and that can swell. So that'll be a concern there. Next thing we look at is the depth. And you might remember there's 3 types of burn depth. There's first degree or superficial, which is kind of like your friction burn or something from carpet. We've all done that. There's second degree or partial thickness. That's where it burns through the epidermis. Very, very painful burn. You've got lots of swelling and blisters. And third degree, which is full thickness, and that's the nasty, black skin, burn, charred, waxy type burn, which ironically is the least painful usually because they burn through the nerves. All right. Then we look at the location. So where is it? Is it in a sensitive area like the hands, feet, face, genital region, whatever? And finally, shock, hypovolemic shock, because as we know, there's lots of fluid loss in a burn, all the serum leaks out. So is there any risk of the vascular permeability causing shock? Okay, brilliant. So hopefully this slider works. So if we look at the casualty's palm and fingers, so this area here on the casualty, and we're assessing a burn area, how much of the body surface area as a percentage is this on a patient? So I've given you a range between 0.5 and 5%. So we'll see if, on average, if we get the right kind of percentage. See if you can remember. All right, so we've got 3 so far, 3.7, 3.5. It's always interesting doing these sliders because they jump all over the place. Cool, 3.4, 3.5. Yeah. Interesting. Yep. So there's about average 3 that we're getting in. I noticed there's a 1 vote or 2 for the lower end of the scale there. Got a couple for 1 and 2. It's actually 1% of the body surface area. And even though that seems quite a large sort of percentage compared to their body, what you've got to bear in mind is that the face, the fronts of the arms, that's about 4.5%. So yeah, it sort of makes sense. So if you're looking at quite a large burn and it's roughly about the size of that, then you could say the burn covers 1% of their body. All right. Right. So somebody's choking. You've done all of the, are you choking? Can you cough? And they're all still clutching their throat. They're starting to show some signs of cyanosis. Who can remember the correct sequence for dealing with that choking? Okay. Abdo thrusts, for those that you don't know, are abdominal thrusts. So you sort of pull in and up on the abdomen to try and dislodge the obstruction. Good, okay. So the verdict's coming in nice and early. 5 abdominal thrusts, yeah. No one going for the compressions then? Good. You haven't fallen for my trap. Absolutely. So the majority verdict is correct. So you start with the 5 back slaps. So between the shoulder blades, you know, good amount of force. You slap once, see if the obstruction's cleared. Slap, check. You do that 5 times. If that hasn't worked, then you move to your abdominal thrusts. So between the xyphosternum and the navel, so sort of right in the middle of the abdomen, about there. Put your hand on top, pull in and up 5 times. Again, check in between each one. If that hasn't worked, then phone to the ambulance and then repeat that process. 5 back slaps, 5 abdominal thrusts. Brilliant. You're on the ball. After a couple of week break, I'm impressed. All right, so final review question before we dive in then. So you suspect someone's having a heart attack. There is a drug that you can help give them that might alleviate some of the symptoms or certainly improve their outcome slightly. Let's see if anybody remembers what it is. Okay, so we've got salbutamol, aspirin. Cool, absolutely right. We've got a couple for salbutamol. Salbutamol is used for asthmatic patients because it dilates the airways, all right? And ibuprofen, it's good for muscular pains and things like that. But ibuprofen is what we call an NSAID, NSAID, which is a non-steroidal anti-inflammatory drug. In the case of heart attacks, the non-steroidal properties of ibuprofen can actually make it worse. So if you've got a patient that you suspect is having a heart attack, the best drug you can give them is usually one tablet, 300 milligrams aspirin. Don't get them to chew it or swallow it wherever, but put it between their teeth and their gum because the membranes are very, very thin there and the drug gets to the bloodstream a lot quicker. Brilliant. So is that all coming back? Excellent. So we've done our Mentimeter warm-up. Now let's see what we're going to be diving into today. So we're going to be looking at pre-hospital equipment. Like I said, throughout the series, I've introduced you to most of the equipment that I use on duty and how I use it. We'll just be covering off a couple more bits which I haven't introduced you yet. And then we'll be finishing off in the second installment of neurological first aid. So we'll be looking at meningitis, how that's diagnosed and how it works. Management of C-spine injury. So if we suspect that somebody's got a cervical injury, a spinal injury, basically, we'll be looking at how we can immobilize that. Migraines, because it's worth talking about because they're quite common, and head injuries as well. What I'll do is I'll blend the two, C-spine and head injuries, into one demonstration, all right? Then we'll be going on to my absolute favorite topic, which is recognition and management of poisoning. We're not talking about cyanide or all the old traditional murder mysteries, anything like that. but it's quite common with children in domestic settings particularly. They find one of those washing machine tablet things and think it looks like a sweet, so they get poisoned. We've also got drug and alcohol poisoning as well. And then as part of our medical conditions, we'll be looking at diabetic emergencies. So we'll be looking at how diabetes works and what we can do to help people with that. And as always, the learning objectives are quite broad for this. It's just to give you that knowledge and confidence. So if an emergency should arise, hopefully this knowledge will give you a bit of confidence to act as the person in charge of the situation. Because even though most of us aren't in medical school yet, just having a little bit of clinical knowledge in an emergency can go a long way for sure. Okay. Another learning objective is to show you some more of the equipment and why we use it, more importantly, what investigations that can help us complete. But most importantly, it's your learning objectives as well, okay? Because this series is for you. So if there's anything that you want to explore together or want to learn more about, ask questions, then we can certainly take a dog leg and explore that together. All right, brilliant. So pre-hospital medical equipment. Now I've introduced you to most of the kit that I carry in my kit bag. There's a couple of bits which I haven't introduced you to yet. So you remember my kit bag there with all the different pouches. It's all neatly organized, so I know exactly where everything is. I don't have an oxygen tank on me because we're in lockdown in the UK at the moment and I can't get to my depot, unfortunately. But an oxygen tank is an oxygen tank. It just contains some of the gas that we administer to people. We've got the suction device here. So if somebody's aspirating or choking, then we put the tube down there and just siphon out. We use the suction to get the fluids out. I've done a series of videos taking you through my equipment, so I'll post those on the WhatsApp chat afterwards as well. Okay, but one thing that I want to do is just show you my observations kit, because it's got quite a few good bits of kit in there that we use to diagnose problems in patients. So let me just turn off my virtual background, you'll be able to see it better. So it looks a bit like a pencil case. What I carry in my bag is because it keeps it all together. So what do I carry in here? Does anybody know what this is? Any ideas? See if we've got anything on the chat.
The thing that you use to check the blood sugar. Oh wait, no, this is for the pulse.
Yeah, then we'll come on to the blood sugar in a minute. So you see, we've got my pulse, which is alarmingly high, and my blood saturations. So we call this little bit of kit a pulse oximeter, okay? We use it on pretty much every patient we come across, unless they've got a little finger cut or something. And it's a very simple device. It just shines a light through your finger, and the amount of hemoglobin in the blood is a good proxy for how oxygenated your blood is. And it also tells us what your heart rate is doing as well. So when we're doing a bunch of observations on the patient, we just pop that in the finger and we just leave it there. We just keep it on because that allows us to see trends over time. All right. So we bung a pulse oximeter on the patient. Another thing, what about this thing? Bit of a weird shape. What do you think this is used for? It's not really an invasive device, so it shouldn't be inserted anywhere. Well, it sort of is, but not too deeply. Any ideas? Thermometer, yes. Yep, this is a tympanic thermometer. So back in the olden days, they used to, well, probably when you were younger, I don't know if your mum gave you one of those strips they put on your forehead when you were ill, bit of Calpol, that kind of thing. In a medical setting, that isn't always the most reliable measure. And it's a bit too invasive using a mouth thermometer, or God forbid, a rectal thermometer. So what we use is a tympanic thermometer. Now, a tympanic is so called because we shove that in the ear against the tympanic membrane, so basically the eardrum. And because it's an internal temperature, it's much more reliable, and it wouldn't be affected as much as, say, taking the temperature from the extremities, because they can get cold quite easily. So if we suspect that there's probably a temperature that we need to check, we just turn the thing on, put it inside the ear, and pull the trigger, and we get a nice readout very quickly. Okay. Next we have, well, I've introduced you to one of these before. Do you remember what this is? That chart might give it away on the side. Yeah, pen torch. So if we look at head injuries or drug poisoning, anything like that, we can do what's called the PHLS test, and that stands for pupils equal and reactive to light. So if I was sat with the patient, I'll just sit down with them and just look inside their eyes, shine shine, and repeat, because I'm assessing a few things. I want to know if their pupils actually react to the light, first and foremost. Then I want to see that their pupils are equal as well. Because if they're not, that could indicate something which we'll talk about a bit later in the session. And then a final good bit of kit that I use, well, pull on from it, is what Amna mentioned earlier on, our blood glucose monitoring kit. Essentially, what you do is you prick someone on the finger and you get a small drop of blood. You just squeeze that out and then you put it on a test strip, put it in there, and it'll tell you what their blood glucose is doing. Quite a useful test to do for head injuries, but particularly if you suspect someone's diabetic. But that's the reason why I've introduced you to these bits of kit, because we'll be using them today. And finally, we don't wear these to show off. We actually do use these for a reason. And we use these when we're taking a manual blood pressure. Now, you can use a digital blood pressure monitoring kit, but I prefer to do it manually because you can also listen to the pulse as well, and it can tell you other things that might be wrong. Now, has anybody taken a manual blood pressure before? Just out of interest? Not many people? Excellent. Well, does anyone want to see how we do it? It's a very simple technique. Lovely job. Right, so to take a manual blood pressure, you need two bits of equipment. You need your stethoscope and you need this bit of kit, which is called a sphygmomanometer. And I have to say that slow because it's a weird name. So let's say we have a patient, you've got your stethoscope, you've got your sphygmomanometer thing, and we want to take their blood pressure, okay? So it's very simple. Just get them to sit down. I'm gonna have to stand up a little bit, but just imagine them sat down. Find an arm, favorite arm, and just get them to relax it, okay? Now, if you follow the line of the bicep, round there, and you go to the antecubital fossa, this pit, around there, you'll find an artery, a blood vessel. Just bonus points, does anyone know what the name of that one is, that blood vessel? No? Anyone want to hazard a guess? No worries. That's a brachial artery, okay? So you've got your radial, which is down towards your thumb. Yeah, and then we find the brachial. So what we do is we get a sphig thing, and you'll see that it's got a couple of arrows there to the line of the artery. What you do is just put the cuff on their arm. This is where it's going to go horribly wrong because I'm having to do this on myself. Make sure the arrow lines up on the arm, put the cuff round. This isn't going to work. Tell you what, let me use my fake arm. All right, just pretend where I'm applying the cuff is about there. All right. So we put the cuff on, like so. Wrap it around the limb. Make sure you've got a nice tight seal. Like so. Right, so we're nearly ready to do the blood pressure. And you see we've got a gauge here. That gives me the pressure inside the arm. And we've got this little ball thing. It's a bit like those old perfume bottles you get, you know, when you sort of spray it, like, and they have a nice mist of perfume or whatever. This just introduces air into the cuff. So what I do now, we're nearly ready, is I put my stethoscope on, put it in the pit, about there, yeah. So I'm actually listening to the artery, and then all I do simply is keep puffing up the cuff, so it'll eventually inflate on the arm, and I keep pumping until I start hearing the heart rate, and I keep pumping up until I don't hear it, and then gradually what I do is I release the pressure ever so slowly until I start hearing the heart rate again. The second that I hear the heart rate, that's what we call the systolic pressure, so the high pressure of the blood. And then we keep deflating, so we should hear the dudum, dudum, dudum in the stethoscope. And once we drop off and we don't hear the heart rate again, that'll be our diastolic pressure. Okay? I'm not going to test you on that. It's not in the reflective workbooks. And without demonstrating it in person, I know seeing it through a video camera is probably not the best means of doing it, but hopefully that gives you a bit of an understanding of how we do blood pressures. And I just saw a flash there of normal blood pressure. It's about 120/80 with some variation plus and minus. But it depends on the age of the patient, depends if they've got any conditions. There's all sorts of things which can define a normal blood pressure. But the main thing to do with taking blood pressures is not to do it once, but to do a series of them so you can see whether it's increasing or decreasing with time. All right, is everybody still with me so far? Lovely job. Double thumbs up. I like that. Right, let me just share my screen again. Cool. So that's the final bit of the equipment that I wanted to show you. And there's some other bits which I couldn't quite fit into my living room, but we can talk about here. So this is about the size of a patient, and this is what we call an orthopedic scoop, okay? So if we have, say, a supine patient, so a patient lying on the back with a suspected spinal injury, we can't just go, oh, sorry, mate, we just need to pick you up, put you on the stretcher, because we risk exacerbating their spinal injury, okay? But what we do here is these two parts, these two edges actually separate. There's a clip there and a clip there. So we halve the stretcher, we take it apart, scoop it underneath the patient's back, and then clip the ends back together. So you don't actually have to pick the patient up. And then once we've done that, we can pick them up and put them onto a stretcher. If we're not worried about their back, but we want to get them into the back of the ambulance, we can use a carry chair. These are our preferred method of moving people at, say, large music festivals, something like that. Because can you imagine trying to get one of those through a mosh pit? It's not going to work very well, especially when people are drunk. People think it's a great laugh seeing a bunch of medics pulling people out and throw beers at us and things like that. So if we've got a carry chair, we prefer to use one of those. All right. This one is a carry sheet. This is usually only used in situations where we need to extract someone very quickly, or we've got no concerns about the state of their body, so no broken bones. That carry sheet is traditionally used, say for example, I don't know, like police training exercises, when they do like terrorism scenarios, things like that. They haven't got time to get the whole orthopedic scoop, stretcher, everything out. They literally bung the patient on, drag them out of there, and then they do the proper immobilization and evacuation. Okay. And finally, we've got our standard trolley or stretcher to you and me, and you've got a little incubator on top there for the little ones. If they're born prematurely, you can put them inside an incubator, a bit like why hens sit on eggs and things like that. All right, so that's just some of the other equipment we use to evacuate casualties. So we've got a range of tools available to us should we need to move somebody safely and effectively. But if you're outdoors and you need to do a bit of first aid, who carries a stretcher with them? I certainly don't. So there's a couple of ways we can improvise. So I'll talk about this bag first. So if we had a kid with us, and I'm talking quite a young kid, they slipped over, knackered their leg, and it's going to be quite hard work to carry them all the way to safety, isn't it? Yeah. One thing you can do to improvise is if you empty out a rucksack and cut 2 holes in the bottom, unzip it, pop the kid in there so their legs stick out like that, and you've got yourself a makeshift caboose. Yeah, you can pop it on your back. Don't zip it over their head because they probably won't appreciate that. But you can use that as a child carrier in the event of an emergency. But if you're outdoors and you're out for a walk with some friends, somebody injures themselves, you can't get a phone reception and you have to move them, you can improvise with a couple of sticks or a couple of poles, a couple of jackets, and that's all you need. All right. You might not be able to hear the sound of this video, so I'll just talk over it. But you'll see behind us, we've got our casualty lying on the ground. That's just me talking away there, don't worry about that. Right, so through that, I've got just a large stick and a walking pole. I've laid them side by side, and I've got a couple of jackets. So I zip up the jacket, pull the sleeves inside and push them down inside, and literally just feed the poles through. So you see I've done that there. So you pull it out, make sure it's nice and tight, move your patient onto the stretcher, make sure it can support their weight, pop a blanket on them to keep them warm, and make sure you have 2 or 3 people to help you, 1 person on each corner, and there you go. You've got an improvised stretcher. Pretty simple, isn't it? Does that make sense so far? I think it's important to talk about improvising because in a lot of first aid courses, they say, you know, you're out on a walk with some friends, somebody injures themselves, just put them on the stretcher and get them to the ambulance. And you just, hang on a minute, who carries a stretcher with them? Yeah. So as long as you've got a couple of poles or a couple of thick sticks and a couple of jackets, that's all you need to do. All right. Right. How are we keeping up with this? Any questions so far? Anyone want to comment or add anything?
Hi, Jamie. Sorry to interrupt there. I was just coming in and out, guys, from different calls. So I just, I mentioned the group as well, but I think let's take a moment to appreciate Jamie's amazing demonstration. Like these videos are not easy to create, right? I think the backstory is that he spent, I think, like he went at 5 a.m. on one of the times, and when it was nice and quiet. And imagine if someone, a passerby, sees him doing that, they'll be like, "What is this man doing?" All right, so he's really doing some next level things. So I think Jamie, let's all give him a massive round of applause already. It's really cool.
Nice.
Yeah,
More than welcome.
fantastic. Just one more thing, just to follow up on that, guys. Of course, you're probably thinking, how would I react or respond in this situation? And that's exactly what I'm thinking. And this is not really just about, okay, how can I put this in my medical school application? Just thinking, if you were in this position, what would you do? Okay, we're not saying that you should go and get some sticks and get your things and everything, but it's an idea of what we can do. But we should always act within our competence, right? Our competence and also our ability. If we're not able to do that, then what's the best thing to do? Ask for help. Yeah, and ask for help is one of the most important things as a doctor, and especially as a junior doctor, because I think even in my experiences on my first week as a doctor, I didn't even know where the drawers were for the papers, the drawers for the blood test kits. So I was asking 100 questions a minute, and that's fine. You have to do that. So the reason why we're having these rhythm checks is that we want you guys to ask questions. No such thing as a silly question. Even if you think, Jamie, where did you record that? Was it in a valley? Was it in a garden? You know, it will spark some discussion. So I think, guys, in summary of that one, always act within your competence and also be safe as well. Yeah, we want you guys to now take away your hats of being a student. You're now someone who's going towards becoming a doctor or a medical student. So you want to try and think, okay, in this situation, if I was a doctor, what would I do? Yeah, and that's the mindset that I want you guys to slowly develop. All right. So Amna had a very good question. So how do you stay calm in these situations? And the true answer is, yeah, I think on the outside, you may look calm because of years of experience, but on the inside, my brain is like doing this. All right. I'm thinking, oh, I don't know what I'm doing. All right. But training will teach you that whenever you're stressed, you will go into autopilot mode. I'm sure Jamie does as well.
Yeah.
But whenever I see an ill patient in the hospital, say there's an emergency buzzer goes off and I go to see a patient, I don't know the patient's name, don't know what's wrong with them, don't know anything about them. It's the first time I'm seeing them, and nurse is saying, "Doctor, please help. Patient's not well." Right? What do you do? Of course, in your mind you're thinking, "Oh my God, I have no idea." But the training teaches you to say, right, think of it in a systematic way, checklist, all right? A, B, C, D, E, right? And then go from there and ask the nurse to help you, right? And once again, important thing is if you think that this is outside your competence and you're not comfortable, get help. There's always someone above you in the hospital, right? Even if you're a professor of neurosurgery, there's someone who's slightly more experienced than you, right? So yeah, that's life, okay? So you can always ask for help, and you should never have that ego that, oh, I'm a doctor, I can do this myself. Yeah, you should always see what you can do to ensure patient safety. Any other questions, guys? Jamie, do you have any thoughts as well, just to add on?
Absolutely. Yeah, I'll second that. I'd say probably a big lesson to take from what Dr. Navin was saying in medical school, whatever you do in the future, is it's okay not to know sometimes, especially in situations you haven't encountered before. People get the impression that the second you put on a uniform or a set of scrubs, you're supposed to know everything. And there's no shame in asking for help if you need it. Nobody knows everything. And even though a lot of the professionals give the impression of they're always staying calm, they don't panic, you know, we've all been in situations like that. You know, my first car accident, or that first pregnant lady which was screaming at my face in 3 a.m. You know, I did not know what to do really. And you have to keep that calm exterior for the patient. If you panic, they do as well. I think what I do to stay calm in these situations is I just take a mental stop, just assess the situation. Right, okay, so this is what's going on, and just go back to these stepped mnemonics. Okay, so we look at the doctor's ABC. Right, what's my next priority? So I've done that. What's my next priority? So just chunk up the problem. Try not to let it get on top of you. But yeah, always act inside your competency. I wouldn't expect you to be doing percutaneous nephrolithotomies or anything like that, because I don't know how to do them. So yeah, I wouldn't even presume to do them myself. So just, if you're confident doing it and you're happy to, great. If not, the best thing you can do is just reassure the patient and just be there for them. All right. So do as much as you're comfortable doing and about as much as you've been trained to do. And that's all you can do. All right.
Brilliant. Jamie, there's one more question on the chat there. Do you think what you'll do from the inside of an ambulance whilst you're on the way, or do you act on the spot when you reach the site?
What is that? How much we do in terms of interventions?
Amno, do you want to just unmute yourself and just explain
Yeah,
what you meant by that question? Go for it.
Okay, so what I meant by my question is when you get a phone call saying, okay, there has been a car accident in this place. So while you're on the way there, do you kind of plan out what you're going to do in your head? Or do you just do everything on the spot when you reach the site of the accident?
Absolutely. Yeah, that's a great question. Usually we get very limited information before we arrive on the scene. So we might get a postcode, we might get an age and a sex of the patient, and one or two sentences of what happens. So we might see RTC, to vehicle, something like that. So in my head, on the way there, you've probably got 5 or 6 minutes of thinking time. So in my head, you go through your checklists, right? So it's a car crash, so I'm going to need my helmet, I'm going to need high vis, I'm going to need oxygen, AED ready, ECG. So you're running through all these checklists. So you go through your checklist as far as you can, but the majority of the information you get is actually on the scene. And that comes back to a few sessions ago. We're using a mnemonic called AMEGA, AMEGA. So we assess the scene, we do what we can to make it safe, then we give our emergency aid based on the history that we've got from bystanders or the history that we've got from patients, the secondary survey. Then we get more help if needed, and we do some aftercare as well. So we wrap up the scene, we do our paperwork, we give statements to the police and so on. So it's probably a bit of both. We do a bit of pre-thinking before we get there, but we don't make any assumptions until we actually get there. We can see what's going on, and then we go through our checklists, so on. Is that all right? Cool. Right, let's crack on then. So neurological first aid, part 2. You remember that we started talking about it last time. We did seizures and strokes and so on. Well, we're going to be looking at some more interesting stuff this time. We're going to be diving a bit more into the brains, get your neurons firing. Right, so we'll be looking at meningitis, what it is and how we diagnose it, migraines, head injuries, and suspected C-spine fractures. So all quite interesting stuff. So the meninges and cerebrospinal fluid. So if you take a cross-section of a bit of skull, much like the skin, it's a bit like a cake, yeah? A bit like one of those coffee cakes. You've got all sorts of different layers. You've got the crumbly stuff on the top, and you've got all sorts of thicker and thinner layers. So obviously on the top layer, you've got your skin. Then you've got a little layer underneath, the periosteum. It's kind of like a thin layer more than anything. The cranium, you've got your big bone layer. And then you've got your martyrs, yeah? So dura mater, arachnoid, and pia, yeah? Arachnoid is basically just like a big web of different tissue and stuff. This will all come in important in a minute. But what's important to know is that there's actually lots of different layers protecting the brain itself. So yeah, their job is all to protect it, absorb shocks, do that kind of thing. But the main 3 layers we want to know about are the dura mater, the arachnoid mater, and the subarachnoid space, the pia, yeah? So these 3 down here. Because in the subarachnoid space, so in this bit underneath, we've got a thin watery fluid, which looks like that. And that's CSF, which stands for cerebrospinal fluid. Yeah, bit of a mouthful. But does anybody want to hazard a guess? Why do you think we've got a fluid in our heads? What do you think it's there to do? Anybody got any guesses? Anyone want to shout out or put on the chat? Relieve pressure, removes friction, yeah. Oh, you're all awake today. You all had your coffee this morning. Yeah, shock absorber. Yeah, exactly that. Spot on. So it actually does a few functions. It does absorb shock. It also removes friction, as you quite rightly say. It also regulates intracranial pressure as well. So because the skull is actually quite a closed unit, the pressure inside it is very, very important. If you have too much pressure, it can cause problems with the brain. It causes a condition which is called compression. And the more compression you have, the more of a problem you have, because obviously the brain affects a lot of functions. And if the brain's being affected by an increasing pressure, over time you're going to get very, very poorly quite quickly. It also does some other functions as well, like removes metabolic waste and some other bits and bobs as well. Okay. So now that we've mentioned CSF and we've mentioned the meninges, this brings us on to meningitis. So as we know, a bit of Latin, the meninges layer, and itis when it's infected or inflamed. Okay, so we've got our meningococcal bacteria here, or it could be a virus, or even drugs can cause a bit of meningitis. And this is what our CSF should look like. If somebody's got CSF and they've done a spinal tap, that's what their CSF starts to look like. Looks a bit gooey, looks a bit yellow, cloudy even. It just doesn't look right. So what's happening here? Well, you can have viruses, you can have bacteria or drugs that could cause meningitis in a patient. And what happens is the infectious agent usually enters through the nose, and it breaks down the mucous membrane at the top of the nose. And the infectious agent actually gets into the cerebral spinal fluid, where it multiplies. It's a warm environment. And this infected CSF is circulating around the brain. Yeah. Now the body realizes that something's infected. It doesn't know what, but what it will do is it will flood loads of white blood cells into that space. So that's the reason why we get swelling with infections, because it's all those immune cells flooding that area. And you'll remember what I said a minute ago, pressure up there is not a good thing, because it starts to press on the meninges and eventually it presses on the brain. Okay. Now, there's a few different types of meningitis. The main two are viral and bacterial. Viral meningitis, it's unpleasant, but it usually resolves on its own accord, usually fixes itself quite quickly. However, bacterial meningitis is a nasty one. That's caused by a group of bacteria called meningococcal, pneumococcal bacteria, meningitis. Coccal just means the shape of the bacteria. It looks like a bunch of grapes under the microscope. Now, the bacterial meningitis is a nasty one that can kill within hours, and usually it's children and young adults which are affected most. It can affect people of any age, but it's a time-critical emergency for that reason, because death can occur very quickly indeed. All right. So, if we suspect meningitis in somebody, we need to know some of the symptoms we should look out for. Okay. Even if we suspect meningitis and we haven't proved it, it's time critical. So get them to hospital as quick as you can, okay? Because it's no exaggeration to say it can literally just be hours from when they're well to when they're, on death's door, basically. So we go back to our chain of survival. Early recognition, noticing these symptoms quickly, then early patient handover. There's not much you can do as a first aider for meningitis apart from recognizing it and making them comfortable. Your priority is getting them to the ED. So some of the things we need to look out for. So if you picture like a really nasty cold or flu that you've had before, it shares a few symptoms there. So neck stiffness, that's quite a giveaway, because the muscles and everything's inflamed around there. So they might struggle to look up or look down. So that's something you can ask them to do. Can you just look up a bit further? So if their neck is stiff, particularly with babies, they might climb up a bit if they're being carried. So that's a giveaway as well. They might have photophobia. So a bit like when we wake up and somebody opens the curtains, you get that kind of aversion to light. Similar with meningitis, but it's all the time. Okay, bright lights really hurt to look at. And then you've got your drowsiness, your cold symptoms, sore throat. That's coupled with a loss of appetite as well, because it's starting to become a generalized infection at this point. You've got your nausea and vomiting. And there's a particular test that we can use for babies. Now, there's a part of their head called the fontanelle. It's probably easier if I just demonstrate with this. So bear with me a second. I've got my baby's head here. Yeah. So let's just draw something on here. This is going to be the worst drawing in the world, by the way. Right. So we've got a baby's head, not particularly happy, but we're not interested in the face. In their skull, the skull's made up of lots of different plates of bone, kind of like a big puzzle, yeah? So you've got one plate there, you've got another plate there, probably another plate, and so on. But quite often, their skull hasn't fully fused yet, particularly in babies, and they have a little area where their bony plates of the skull haven't fully formed together yet. So it's literally a boneless area in their skull, and that's what we call the fontanelle. Now, in a normal baby, you can, don't press too hard, but you can press on their fontanelle and it's supposed to feel a bit spongy. Yeah, there's not much resistance there. Probably feels about the same kind of pressure as this balloon's giving off. But if a baby has meningitis, all of that inside the brain is inflamed. So their fontanelle is actually going to bulge out a little bit. It's going to be very, very stiff. So that's a test we can use. So if their fontanelle is not spongy when you press it, and it's actually quite hard, that might be a warning sign of meningitis. Yep. Cool. So those are some of the symptoms of the meningitis there. There's another test that we can use as well. In some cases of meningitis, you can have what's called a hemorrhagic rash, which looks a bit like that. It's kind of like a nasty, blotchy, purpley kind of rash in cases of acute meningitis. However, most other rashes, if you press a glass on the skin like that, because of the pressure, the pinkness will disappear underneath the glass. But a big giveaway for meningitis, if you press a glass on the skin and it still looks like the rash underneath, that's a key giveaway for meningitis there. All right. Right, so I'll just catch up with the questions before I speed on then. Yeah, that's cool. Yeah, there's a few early signs. Yeah, traditionally the earliest signs of meningitis, like we just discussed, kind of like cold symptoms. Babies might have a high-pitched cry. Photophobia and the rash are the sort of two big giveaways there. But all of these symptoms may present differently or in different times, which is why it's important. If you suspect meningitis, just treat it as if it is and get into hospital as quick as you can. All right. Brilliant. So that's meningitis so far. The first aid, like I said, is quite limited. Just make them comfortable. If they're complaining of being too hot, see if you can cool them down a little bit. But your main priority is just get an ambulance down there as quick as you can. All right. Cool. So migraines. Just out of interest, does anybody here have migraines? Does anybody get them quite badly? You can unmute yourself or put it on the chat.
Yeah, it's horrible, Jamie.
Yeah, I know a few people who get them. Yeah, do you want to describe, well, I mean, if you're comfortable to, do you want to describe what it's like having a migraine?
There are small triggers, and I usually find that if I have orange juice, that's when it first starts. I have no idea why, but I stay off it. Yeah,
and when you actually have the migraine, do you get an aura or any sort of visual symptoms?
Around, you feel sort of sick and you don't like light, and it's a pain all around my head. I can't really explain it.
Well, I think it must annoy you when people say, oh, it's just a headache, because it probably isn't. It's a lot worse than just a headache, isn't it? And when you do get them, how long do they usually last for?
Roughly 2 days.
It's really interesting. Thanks for sharing. We've got a few people who get them as well. Jana gets them. Anna saying it's a hereditary. Sarah, the sister gets it the right side. The vision gets blurry. Sees circles. Yeah. So I've only ever had one migraine myself, and even then that wasn't a very bad one. I just got the shimmering in my vision and things like that. But some people get them really, really badly. Some people, like Isabella was saying, literally have to lock themselves in a room for a day or so in a dark room because it's a crippling pain around their head. So we've got some common symptoms of migraines. First and foremost, it's a severe headache, but it also, because of the chemical imbalance and all sorts of weird things going on in the brain, it can affect the other senses as well. So you might get a bit of tinnitus, a bit of ringing in the ears. You might get what's called an aura, which can either look like shimmering in the edges of your vision, or you might get kind of like a tunnel, like a grey tunnel, and it gets narrower and narrower. Or you can get other kinds of visual disturbances as well. Photophobia, again, vomiting, nausea, it's really not very pleasant at all. All right. Luckily, most of the time, people with migraines know that they get them, so they'll probably have some kind of medication to manage them, or at least make them a bit less worse. So they might have what's called an antiemetic, basically an anti-nausea drug like Maxol, or they might have migraine medication as well. Isabella, do you have a particular medication that helps with it, or anything that you take, or do you just ride it out usually?
It's only recently started, so throughout A-level, that's when it started happening. So I thought they were just headaches, but now I'm considering the possibility that they are migraines. So happening more often, but I haven't got any medication for it.
Yeah, fair enough. And yeah, somebody made a really good comment on the chat as well. It's not one of those kind of things that you can just take a bit of anodine or something and it will just cure it 100%. And as Dr. Nevin was saying, the diagnosis of migraines, especially if it's happening to someone for the first time, is actually really difficult. Because if you look at some of these symptoms, you've got your headache, intolerance to light and sound, neck stiffness, is it meningitis? Is it a stroke? Is it something else? Anything neurological is quite difficult to diagnose, which is why we're relying on the fact that most of the time people know that they get the migraines. And 1 in 7 people get them. So it's not an uncommon disease by any means. And they still don't really know what causes it. There is a genetic factor in them, but there's all sorts of triggers as well. Like Izzy said, it's orange juice for her. Some people, they get it from aromas, like weird kinds of smells. Some people get it from looking at a screen all day. That's certainly how I got my migraine that time. But there's loads of different triggers and anything can set it off. Yeah. And yeah, like we say, a lot of people, even in this group, get migraines. So you can assume that a lot of people elsewhere get migraines too. Yeah. So yeah, a lot of people do manage it on their own, and there's not much you can do. But if you really want to help, you can help them take their medication. I've certainly helped people in the past where the pain is so severe, so acute, that they can barely open their eyes to look at their medication, but they still want to take the medication. So you can't administer or prescribe medication yet, but if they have something that they do take and it's in the correct dosage and there's no contraindications, you can help them. So give them a glass of water, introduce them to their medication and help them to take it. You can also get them to lie down and sleep as well. So if somebody's got a migraine, say in an office, get them to a quiet room, somewhere where they're not going to be disturbed, or spare bedroom, something like that. Shut all the blinds and just give them as little sensory distractions as possible. Just lie down in a dark room, leave them alone. They might get quite bad nausea as well. So if you've got a bowl or a bin or something, so they don't have to get up and force themselves to go to the bathroom, that'll help them as well. And yeah, use your clinical judgment at this point. Now, I know a lot of you aren't professional medics yet, but you can use your judgment here. So if you think it's just a normal migraine, that's fine, just leave them be, that's fair enough. But if they have any weird symptoms, like we've discussed in the previous session, like the fast test, if their face starts drooping, if they get shaking all over, weird vision, or any of these symptoms here, if it's gone on for a few days, if it's really crippling pain, stiff neck, basically any of the symptoms of meningitis, stroke, anything like that, forget migraine, just get them to the hospital and get somebody to check them out. Yeah. Is everybody all right with this so far? Making sense? Cool. Well, yeah, I've just kind of given it away. Strokes and meningitis might be confused with migraines initially, some of the earlier symptoms. Right, before I do a quick practical demonstration, has anybody got any questions so far about any of that? No? Anything on the chat? Or you could just unmute yourself, it's probably easier. Anybody got any questions?
Wait, so if the patient is unconscious, how can you tell if there was like, I wouldn't say head injury because I feel like that's kind of obvious, but anything like meningitis, how would you suspect that? Because there are so many reasons why someone would be unconscious.
Yeah, exactly. The meningitis, unless it's actually in its latter stages, they shouldn't be unconscious. So they'll know that something's wrong with them. They'll feel very, very fevery, quite unwell generally, which in its initial stages could be a million and one things. I mean, it could just be a cold for all we know. But that's why we do these further diagnostic tests, like the glass test. We see if they've got any photophobia, neck stiffness. We have to take all of these symptoms together and basically just tick them off. Do they have that? No. Do they have that? Once you've done a few assessments, if you don't think it's meningitis, you can start looking at other things. But it's like any kind of first aid. You start with the most severe thing it could be and work your way down. So as you say, quite right, meningitis is always time critical. So in the initial stages, they might seem okay, maybe a little bit ill, but it's that rapid decline that's usually indicative of something more severe. So that's at the point where we start thinking, right, meningitis, into hospital now. Yeah, does that make sense?
Yes, thank you.
Ah, no problem. Any other questions? Cool. Right, so head injuries and C-spine. So we've all seen, or probably been in a crash on a bike or a scooter or something at some point. I'm certainly guilty of that. I've crashed my bike a few times. Luckily, I've usually walked away from it, but particularly in sports or high impact activities, things like rugby or things like that, people have the potential to come to quite significant head injuries and C-spine problems. If a head injury is quite minor, we can usually deal with it. They always look worse than they are initially because, as you remember our diagram, there's a bit of thin skin there and then not much else but bone on the skull. So the skin's actually really tight on the forehead. It's stretched like a drum. So any tiny cut is going to bleed and bleed and bleed. But as long as they're fine and they're still talking to you, they're still A on the AVPU, then usually it's okay. But head injuries can also be quite severe as well, and they can affect the brain. There's a few different problems that you can get with severe head injuries. You can get concussion, which is when the brain's shaken inside the skull. Has anyone eaten a Scotch egg before? I'm not sure if they have them where you are. It's kind of like an egg sort of wrapped in sausage meat. No? Right, forget it. The reason why I brought it up is because when you shake a Scotch egg, you can feel the egg shaking around inside. Similar principle for the skull. If you impact the head hard enough, the brain's going to shake inside the skull, and that can cause some minor symptoms, which we call concussion. But another problem we can get with head injuries is a condition called compression. Now, compression is when there's a bleed caused inside the skull, usually from the brain, but it's got nowhere to bleed into. And you remember what we were saying about pressure on the brain? So it's bleeding and it's still bleeding inside, but it's got nowhere to go. So it's compressing this brain more and more and more. And if somebody's had a head injury and they're starting to lose coordination, their pupils are unequal, they're not remembering what day it is, they've had behavioural changes, these are all warning signs of compression. And that's another time critical emergency, because eventually what they're going to have to do is probably just drill a hole into the skull to relieve that pressure. If they really cannot drain it any other way, they're going to have to do a surgical intervention. But if we've got a head injury, a big giveaway is the pen torch, which is why I mentioned it earlier. So somebody's got a head injury, we always do the pen torch. So we look into both their eyes, see if they're pearler. Now, the reason for this is because in a compression injury, their pupils initially are usually equal, but over time, one pupil dilates and the other one constricts. So you've got unequal pupil sizes. Now, unless you've got a pre-existing medical condition, it's quite unusual to have unequal pupil sizes. So you just basically have to do a bit of mental arithmetic. Have they got a head injury plus unequal pupils equals possible compression? Yeah. And then the further into the compression they get, eventually both their pupils dilate and they become unreactive to light. That's usually a terminal sign. That's usually when they're pretty much dead, more or less. But if you can catch compression early by doing that pen torch, even a phone torch will do. Just put your hand between their eyes, shine it in both their eyes. Are the pupils equal and do they react to light? If they don't, then you can suspect something's probably wrong in the head. All right. So we've discussed concussion, we've discussed compression. Now, what's C-spine? Well, C-spine effectively, let's take an example. Somebody's fallen off a ladder, yeah? You've got a significant amount of blunt force trauma to the body very quickly. And the neck, if you think about it, it's just a thin line of bone holding your quite heavy head to the rest of your skeleton, yeah? So if there's an impact, it might dislodge a vertebrae, the spinal cord might be compromised. So if you attend a car accident or anything where somebody's got a severe head injury and they've been knocked unconscious or they've got pins and needles, anything like that, you always have to suspect that there's something wrong with the spine. Yeah? And that's what we mean by C-spine. So I've got our friend Annie here, and we'll do a quick practical demonstration to have a little bit of a chat about some of the things that we can do to stabilize them. Now, let me just move my camera a little minute. Bear with me a second. Can you see our friend there on the table? Yeah. Can you see the head? That's the most important bit. Yeah, lovely. Right. Bear with me a second. So let's say in this scenario, you've been called to a chap who's fallen off their ladder. You come in, they're on the floor, you can see they've got head injury. So the first thing we need to do, obviously, check for danger, which we've done. The step ladder's been removed, but we need to put on our PPE. And we need to go through Doctor's ABC methodically again. So the next thing we do is check for, does anybody know? Shout out. We've done the danger. The next thing we need to check for? The R. Anyone remember that?
Response?
Yes, absolutely. So approach them from the side if you can. Hello? Hello, can you hear me? Open your eyes. Come on. Right, so they're not responding to voice, they're not responding to pain, so they're unresponsive. So the next thing we need to do is check for any catastrophic hemorrhage. And by that, I don't mean like a simple bleed, I mean like arterial spurting blood. Can't see any catastrophic bleed, so the next thing I do is check the airway. However, because at this point, I'm initially suspecting a C-spine fracture. Hang on, let me just move that. Because I'm suspecting a C-spine fracture now, you can't tilt their head back to look at the airway because you might risk making it worse. So there's a technique that we use to maintain an open airway called the jaw thrust. And I'll demonstrate that to you now. All right, sorry, this tripod's a bit flimsy. There we are. Right, so because I'm suspecting C-spine, I can't do that because that'll put pressure on the neck and the occiput will ensure that it's exacerbated. So if you've got a friend with you, get them to basically put the thumbs on the casualty's cheek, put the fingers underneath their jawline, and pull up with their fingers. It'll be uncomfortable, but it maintains basically like a reverse overbite. It keeps their mouth open like that, so they can still breathe through their mouth. That's the jaw thrust technique, okay? So we've done the airways now. Next thing I want to check is whether the casualty is breathing and breathing normally. So I look down their chest, I look, listen, feel for breathing. Let's say the casualty is breathing, okay? So I don't need to do CPR yet, but I've got to keep an eye on it. So we've made sure that there's no catastrophic bleeds, casualty is breathing, and they've got a clear airway. So what do we do next? The next thing I want to do is have a quick look at this head injury. Now, is it deep? Is it severe? I don't know. So I'm just having a quick look. It looks like it's just a small bleed on the head. This casualty is unconscious, so I can't ask them about it yet. But because I'm suspecting a C-spine, that's the next thing I need to prioritise, okay? So there is an item of kit that we carry in our pre-hospital bags. Does anyone know what this is? What we use it for?
The neck.
Yes, the neck, yep. This is called a cervical collar. And basically you apply it to the patient like that. Very uncomfortable, it looks stupid, but it keeps their neck nice and still, okay? So for our friend here, we suspect that he's got a spinal injury. So I want to immobilise his neck as quick as possible. So without moving him too much, I have to move this dummy a bit, but that's only because his neck isn't, but move him as little as possible, get the collar underneath them, and bring the neck part round, like so. So that bit's under the chin, and then bring the collar round and attach it like so. So if he did wake up and try to move his neck is now immobilised. So that's part one, so that's all good. We've now immobilised his neck, and that's taken a few seconds. The next thing we can use are these bad boys. Anyone got any idea what these are used for? Right, let's show you. These are called head blocks, and these can be used with an orthopaedic stretcher. You might see them on programs like A&E, things like that. Literally all you do, these holes go over the ears, and you just put blocks against the head like that, so it keeps the head nice and stable. And then literally all you do is put your straps on underneath the blocks, make sure that you've got it nice and secure everywhere, get it over the forehead, and just make sure that the arrangement is nice and tight. And then if you've got any micropore, tape, straps, anything like that, then you could just secure it even more. Now there is a rule that we use with cervical collars, and the rule is that once you've applied one, you can't take it off unless a doctor has taken it off for you. The reason for that is because removing a collar moves the neck a lot. So it doesn't matter if you put one on wrongly, and they don't need it, that's fine. But once you've applied one, you can't take it off unless you're a doctor, okay? So we've done all this now. We've got our head nice and immobilized. The next thing I'm going to want to do is just make sure we've got a defib and oxygen nearby, just in case they stop breathing. So I'll put that next to the patient, should we need it. So we're doing all these things in order, you see. So we've started with the most severe stuff. We've got a patient nice and immobilized. Because he's had a head injury, I'm probably going to get him on some oxygen as well. So we'll attach our mask, make sure the reservoir fills up, attach that to the oxygen. So he's starting to look a bit more like a patient like you'd see in A&E at the moment, yeah? So we've covered off our priorities so far. We've stabilised his neck, we've ensured that his airways are clear, he is breathing, but we've got some oxygen on him, he's immobilised. There's one final thing, well, a couple of final things that we can do whilst we're waiting for the ambulance crew to arrive. The next thing I'd want to do is just have a quick look inside his eyes. It doesn't matter if he's unconscious, you can still prise open the eyes. Now, try not to open the eyes by lifting the lids apart like that. Try pulling the skin up on their forehead, because that means that they're probably more likely to be looking up. So just have a look at each eye. Right. His pupils are equal at the moment and they are reacting to light. So I'm not suspecting compression just yet, but I'll check this again every 5 minutes. So we've done that. And the final thing we can do is just take the time before we do our secondary survey to have a quick look at this head injury. So I've got some saline pod just to wash away any obvious blood. And I'm just having a look. That cut doesn't look too bad. I think that's just a skin cut. So he's probably unconscious, suspected C-spine, but otherwise no major symptoms so far. And that's the gist of head injuries and C-spine. Now, if you're on your own and you don't have a fancy medical kit like me, there are things you can do if you suspect someone's got a C-spine. Just give me a second to take all this stuff off. Right, let's say you came across a traffic accident and you've got the driver sat in their seat and sat back into the seat, okay? Now, you don't have any of this stuff with you. The best thing you can do for them is a technique called MILS, which stands for Manual Inline Stabilization. And essentially, you just sit behind the casualty, you make a kind of like Vulcan salute, like that, leave their ears uncovered so they can still hear you, and you do that symmetrical on both sides. You probably won't be able to see that very well. Just imagine that upright. And you literally just hold their head still like that. Yeah. And you keep holding that until somebody can take over from you, kind of like CPR. Once you start holding them, unless they stop breathing or you need to do CPR, don't let go. Keep their head nice and stable. And once they become conscious, they'll probably be a bit confused. They'll probably want to move. Be firm if you have to. Just say, no, keep nice and still. There's a reason why we're holding your neck. Just stay still, all right? And that's your MILS technique. All right. So if we review that then, we've looked at what we do for a head injury, i.e. have a look at it, we wash it, see if it's severe or not, check the pupils. If it is a severe head injury, get them down to hospital to get checked out. Now, you'll remember there's two, like the golden two that we use with bleeding, because with fractures we did stabilise and immobilise. Does anyone remember what the key two for bleeding are? Two things. Pressure and elevate, spot on, well done. Now, if somebody had a head injury, there might be a fracture there. Do you think applying lots of pressure is a good idea? What do you think? Yes, Sarah? Oh, right. Yeah, that's all right. Yeah, try not to apply too much pressure. It's enough to put a bandage on. I mean, if it's really bleeding and they're bleeding out, then yeah, fine, put the pressure on. But if it's just a little head wound, just get them to hold a pad if they're conscious, or put a bandage on there quite quickly, and that'll be enough. But if you suspect C-spine, that has to take priority, okay? So keep their head nice and still, put a collar on if you have one, and job's a good one. Now, does anybody have any questions about any of that? Anything that's missed? Lovely.
Hi, Jamie. I'm just dropping back in.
I know, you're right.
Yeah, all good. Thank you, guys. I was just watching in awe once again. To be fair, I think I'm just coming in. I'm almost like a spectator now, actually. Enjoying the spectacle of Jamie's doing his live demonstrations. Once again, amazing demonstration. He's even put some fake blood on the on the Annie as well. I'll pick that up as well. So that's really, really good, Jamie. I think I'll tell some stories now in terms of, there we go. There we go. So in terms of head injuries, guys, I think working in the emergency department, I think for me, head injuries is the most scary thing to assess. Okay. Scary meaning that patients, as I said before with meningitis, young patients have a really good compensatory mechanism, which means that they have to become really, really unwell to become like, as in they're showing symptoms of becoming unwell, right? Therefore, you need to go back to your principles of neurological examination. And in medical school, the cranial nerve examination was the most difficult examination for me to learn because there are 12 cranial nerves. And you've got to think for each one, is it a sensory nerve? Is it a motor nerve? Is it a reflex nerve? And imagine it's 2 or 3 a.m. You're slightly tired. It's been a while since you've had your dinner. You need your coffee and some time. And a patient's having head injury and they're not really giving you much of a history. So you have to go back to your training and think, right, let's go from, it's a bit like doing doctor's ABCDE, but imagine it's on another level of doing cranial nerve exams. So that's one thing. And then thinking, what is your risk tolerance? Do we do a CT scan now or do we do it in 8 hours? There are nice guidelines that says if patients had vomiting, loss of consciousness, you do it now. But at the same time, if patient's not telling you that, you have to make that decision and only you will do it, right? No one's going to come and ask you, well, what should we do? What should we not do? Everyone's busy, right? So I remember distinctively, there was a young lady who said that she opened a cupboard into her head, right? So it sounded a bit, it sounded very common, doesn't sound too bad, right? But then I was doing an examination of her head, and I saw there was some bruising behind her ear. I was thinking, that doesn't look quite right. Because even if you opened it really hard, why would there be bruising behind the ear? Yeah? So I'm thinking now, I'm putting my detective hat on. You have many hats as a doctor, right? I'm thinking, what else is going on? So I took a step back. I looked at her outfit and everything. It was in the middle of the night. It was 4 a.m. I was thinking, why is this person wearing clothing as if she was going on a night out or somewhere outside? Surely she should be in pajamas, right? And she was getting, a snack in the night. So I was thinking something is not quite right here. And then I looked in her surrounding area. She had like a backpack. She had some clothing packed, like a big duffel bag. I was thinking, this is now getting really strange. The story doesn't make sense. Then I said, okay, who brought you in? And it was her boyfriend. And I was like, had a look in the waiting room, and the boyfriend looked really nervous, and he was like looking at his phone, looking at his watch, and thinking, he's a bit itchy here. So I'm thinking maybe something is not quite right here. So to keep things simple, I just asked the nurse to have a look up to the patient. I had a very quick chat with the boyfriend and see if the stories matched up. And the boyfriend said, oh, she just fell down. We were going for a drive and she fell down. And I was thinking, hang on, red flags are alarming here, right? I thought, right, let's forget everything, go back to our thing, assume the history is completely incorrect, and just see on the symptoms. Now, the bruising behind the ear is something called a base of skull fracture, and it's a medical emergency, right? If you do not CT scan that and do neurosurgical intervention in the next few hours, a patient may have internal bleeding, and they may die, right? So we thought, let's leave the police stuff out of the way for now. Patient safety is my number one priority. Let's get an emergency CT scan. And, as you know, the results said that there was a base of skull fracture. We called the neurosurgeon. She had an operation at 5 a.m. and she was fine. Okay. So the moral of the story there is that, of course, you have to listen to the patient, take a history, but you should always think clinically as well, right? If it doesn't make sense, don't just take anyone's word for it. If it makes sense, fine, but always have that suspicion. You're a doctor and you're there for the patient. Okay. So I hope that gives you a bit of an insight into real life. And to be honest, head injuries, once again, they are most difficult because it usually means that patient has cognitive impairment, which means that they may not be able to give you a history, even if they are competent enough to do that. Yeah. So hopefully that gives you a bit of a memory now. And if you see any patients with head injury in the future, you should think about our session and think, let's just, of course, start from the beginning and make sure that we do things clinically and in a systematic way. Okay. Amna had a quick question. So what if they agreed on a story before they came in? Yeah, once again, to be honest, it would still not make sense. Even if the boyfriend said she opened a cupboard door, the mechanism of injury doesn't relate to what you're saying. Okay. Say they thought, okay, let's say that she fell down, right? The thing is, you would have to fall down quite significantly to have a base of skull fracture. And the base of skull fracture usually happens with traumatic injuries from the back. If you fall down, you're usually falling forwards, right? and if you feel falling backwards, usually your reflexes are really good. You actually put your arm up or something. So unless she was intoxicated on drugs or something, it wouldn't make sense. So you should always have a low threshold to try and further investigate. Of course, this is a really rare occurrence. This wouldn't happen every day, but the reason I remember it was because it was so memorable, right? Because it was such a, almost like a Hollywood story, isn't it? Yeah. So I think from there, it makes you realize that yes, we have to seek patients clinically, but we should always think about the whole patient management as well. Okay. So yeah. So final thing on that, Jamie. So I'm just asking about social services. Yeah. So we would do that, but in terms of urgency, that's not the urgent thing at the moment. She's in a safe environment. We're looking after her. She can go for a CT scan, go for a surgery. And once she's on the ward, then we can do that in our own time. Okay. Sorry, Jamie, I was talking for too long there, but hopefully that was a good story for you.
Oh, it's really good to have context like that. And Dr. Navi made a really good point in just how complex head injuries are. So the reason why we did the whole demonstration, things like that, is because it's interesting for you guys to see how we'd deal with it and stabilize it and so on. But what I'd say from a first aid perspective, especially if you don't have any of that kit, is just always err on the side of caution. If they look at you, they find the pupils reacting normally, they've just got a bit of a bleed on the head, but they're still telling you they're fine, sit with them for 5 minutes. If they're still all right, then it's okay to let them get on with it. But if you're not entirely happy with anything that they're saying or doing, or you think that there's the possibility that it might be a problem, get them to hospital to get checked out. It doesn't always have to be an ambulance job. You can just drive them to A&E, but always get them checked out because they are complex. All right. When we were sorting our friend here as well, one thing I forgot to mention is when you're looking at their head, you're also looking at their ears as well. Because if you see blood or like a clear watery fluid, basically CSF coming out of their ear, that's indicative of a very severe C-spine injury. So you definitely do all the whole holding head and everything then, all right? So have a look at the ears as well. Brilliant. Thanks, Dr. Navin. That's a great story as well. Good context. Cool. Right. So that is C-spine and head injuries. Now we're about to move on to my favorite topic, which is poisoning. Right. Let me just share my screen again. Cool. Can everyone see that all right? Lovely. Cool. So we'll be looking at the recognition and management of poisoning. So let's get back onto our Mentimeter a second. All right. So I'll give you a second to log back into this. It'll be same code, same website. So I've just got a couple of questions to kick off the poisoning part. Right, so your comments will pop up on here. You can submit more than one time. How do you think poison can enter the body? What sort of different ways can it enter the body, do you think? Yep. Got lots of ingestion there, lots of mouth. Yep. Any other ways you think? Yeah, injection, that's a good one. Parenteral, respiratory, GI, skin, eyes. And so 1, 2, 3, 4, 5, 6. Yes. Well, you've covered it all between you. Absolutely right. So there's 5 different ways that the poison can enter the body, which we'll talk about in a minute. Brilliant. And this one's just a pie chart to gauge opinion. So somebody's taken a poison, they swallowed something. Do you think it's worth trying to get it out of their system? Try and make them sick. Get out of their system, do you think? All right, so we've got some for yes. Interesting. Very interesting. There's a verdict here. All right. So I'm afraid most of you are wrong. If somebody's ingested a poison, don't try and make them vomit. If they vomit on their own accord, that's fine. Leave them to it. But there's a couple of reasons in films and things like that. Somebody's taken a poison, and has anyone watched Casino Royale, that James Bond film? Some of you have, some of you haven't. But there was a scene in it where his drink was poisoned, and he went to the bathroom and basically poured a load of salt and water, and he swallowed it to make himself sick. A lot of films show that you should try and make people sick if they've been poisoned. the reverse is actually true. The reason why we don't force them to vomit is a couple of reasons. The first reason is it could block their airway, especially if they aspirate and it gets stuck. The second reason is that the tissues in the pipes down there are actually quite thin. And if you bring the vomit back up, that vomit is going to contain the poison as well. So you're effectively poisoning them twice. Yeah. So if somebody's poisoned and they vomit on their own, fine, okay, no worries. But don't try and make them sick. So don't do the whole fingers down the throat or salty water or anything like that. Cool. But good answers, well considered there. So that was just a couple of questions to get you in the mood. So we've done that. Let me just stop share. So I've got a tray of some items that are common household. All right. So let me just bring this over. I've just got to handle this carefully because it's got fluids on it. So I'll give you 30 seconds to look at this tray. And all I want you to do is tell me which substances on there are poisons. All right, so you've got shower cleaner, you've got an egg, you've got a packet of pills, some water, salt, and washing up liquid. So I'll give you a few seconds to look at that. So just have a think about what items on there are poisons and which aren't, and we'll have a bit of a discussion in a second. Okay, so we've got a few takers for washing up liquid so far. Wine, ferrium, bleach, yeah. Washing up liquid, alcohol. Cool. Right. One of you got a really, really good answer on there, and I'll explain what it is in a second. So let's take each of these items sequentially. All right. So water is a poison. Drugs, poison. Egg can be a poison. Definitely a poison. Definitely a poison. Can be a poison. Can be a poison. The reason why I got you to do that exercise is because everything, every substance, even water, oxygen, anything can be a poison. It just depends on whether it's the wrong dose or not. So the common household items, let's say water. There is such a thing as water intoxication. And there was a case a few years ago where a radio station was having like a phone in, and I think the competition was you'd win a TV or something if you managed to drink as much water as you could in 5 minutes, something like that. So this lady basically swallowed, I think it was something ridiculous, like 6 or 7 liters of water in a couple of minutes, you know, masses and masses of water. But she actually killed herself doing it because all of the chemical processes in your body are quite finely balanced, basically homeostasis. And by quaffing all that water, what she did was she upset the electrolyte balance. So there's nothing conducting anything then. She's basically overwatered the system. So eventually all of those electrical impulses stop, and that includes the heart, the lungs, the brain function. So you can kill yourself with water. Salt, yeah, again, that upsets all sorts of chemical processes in your body. Eggs, you can have salmonella in there, which release toxins, which poison the system. Ibuprofen, NSAID, you can overdose on that. And these chemicals like this, they usually have warning labels on them because they're full of all sorts of nasty stuff as well. So I think it's Sarah in the end who said all of them depending on the dose. So yeah, 100% right. Yeah, well done. Does anybody have any concerns or problems or comments they want to make about that? Yeah. What I will say is that some substances you have to really abuse for them to become poisonous. Things like water, I mean, you have to drink a lot of it. Oxygen, you have to really overdo it as well. But it's all about the potencies of different chemicals. So household cleaner, you'd need a lot less of to have toxic effects than, say, alcohol. But once you overdo it on the alcohol, that will probably end up having similar symptoms. All right, so it's all about different substances. And we had a question about, is pure water poisonous? Any kind of water is poisonous. Some types of water are more poisonous than others. There's, I don't know whether any of you have done physics, but there's a type of water that they use in nuclear reactors called heavy water, which basically has a few more bits and bobs added onto the atoms. The body can't process that because it's used to the pure sort of H2O. So drinking heavy water will poison you much faster than normal water. But as for the purity of water, it doesn't really matter. It's roughly the same kind of dosage. All right.
Jamie, just to interject very quickly there, do you know what? That was a really, really good, like real life summary actually, because once again, these are the kind of things that they don't really cover in medical school. I don't know why actually. They probably should. They should probably hire Jamie as one of the professor of like hospital medicine for med school. But I think just on top of that, so with what he's saying about dosing is really important, especially in patients who are drug addicts. Okay, so you probably see what the most common things you might see on TV is that this celebrity or that celebrity died from an overdose, right? But what does that actually mean? And it's really, really complicated. So someone taking, say, 50 grams of heroin in just one go is very unlikely, right? They usually started on 1 gram, 2 grams, and so on, so on. And when they do that, the body is becoming more and more adapted. Therefore, their toxic level of dosing is increasing, okay? Therefore, their tolerance is increasing. Now, once they go off the drugs for rehabilitation, for getting clean, etc., right? Their brain is thinking, the last time I had a dose was 50 grams. Therefore, that is the dose that will give me the high. Because previously they realized that 2 grams doesn't do anything to them anymore, right? So their last memory is of having that one. And after 1 year, when they sometimes relapse, they think that, what should we do? Should we try 2 grams? It didn't work, but did it? Maybe let's try 40 and see if that works. But then if you go from 0 to 40 grams altogether, that is becoming like a double or even quadruple of the dose that their body is now used to, and that will become a serious overdose and becomes a poison. Yeah, so that's when they have this overdose and they pass away, right? Because think about it, if someone is a seasoned user of these kind of drugs and everything, it's very unlikely for them to pass away because they know their tolerance. But once they start not knowing their tolerance and not knowing what their body can and can't do, that's when they get the side effects and they have their bad outcomes. So it's all about context, and I'm really glad that what some of you guys have mentioned. I think it was Sarah who mentioned that. It was really, really good, actually. Very well done. It's about your own body, and one more thing on top of that is about genetics as well. Okay, so even forget about all these poisons or drugs or illicit use. Even in common medications such as codeine, which is a opioid medication, some patients have a genetic tendency where they are really good at metabolizing codeine, and therefore it doesn't actually work for them, right? Therefore, you give them codeine and they don't have the pain-killing mechanism, but it's still activating those receptors and it's still causing the respiratory depression, it's still causing all the other side effects of the codeine. But they think, if one tablet doesn't work, maybe if I take a couple more, it might work. And eventually it will never actually give them pain relief, but it will put them to sleep, and that will then cause them to die, right? So it's all really interesting, okay? And when you go into medical school and you learn about it, you see the trends in the different types of both acute toxic poisoning, that people have overdoses, but also even harmless, yeah? Some patients are allergic to things. Even allergy could be seen as a bit of a poison, right? It's just the body's own immune system overreacting to something. So it's a bit of an interesting topic, and I'm glad that Jamie is mentioning it today. I hope that gave you some more clinical context, Jamie.
Just out of interest to know, have you dealt with any cases in the hospital of poisoning? People have been admitted, not just for drugs, but like anything more exotic, like household cleaners or anything like that?
Yeah, I have actually. So when you work in the emergency department, especially in London, you get all sorts of random things. I think the most common one is paracetamol overdose. Okay, I'm sure everyone knows that. Yeah. So some is really sad in some ways because not all of them are intended overdoses. Some of them are just overdoses. They know that they take like 6 tablets. It's not going to kill them, but it's classified as an overdose, and therefore they go down the mental health pathway. And then you asked them, so, what happened? What was the story behind taking it? And they said that they've been waiting for weeks and weeks for mental health support, and they were still waiting, and they wanted help now. And doing that process was the only way to get them down the fast track. So there are some other reasons why someone will do that, but the more common things is to either for self-harm, they have some sort of mental health side effects, or they want to commit suicide. So so the other weird and wonderful things I've seen is organophosphates. So these are the cleaners. Yeah, so these are the ones that are really, really strong. So like the industrial, like washing up liquids, or like car cleaners and that kind of stuff. And those are really, really hard to manage because what happens is they're not just poisonous, they're also irritant as well. So what happens is when you drink it, they're really acidic. So it causes burn injuries all the way in their upper airways and their esophagus, and sometimes they aspirate in the lungs as well. So even if you've removed the substance with medications and reversal agents, you still have to manage them for weeks on end with their chemical burn injuries as well. And I think the one that stumped us the most recently was someone had overdose of scorpion sting. I'm not even making this up, all right? Yeah, this is something that, only happens in movies. But there was someone who was working in some exotic pet shop, these reptile pet shops you get. Yeah, so they somehow extracted the poison from the scorpion in like a bowl and just drank it, right? I don't know how or what happened, right? And they wouldn't tell us what animal it was or what thing it was, because they wanted to end their life. And we went through the full tox base. So when you're a doctor and you have no idea what the toxin is, you call the toxic lab, right? And they will just give you the common things, and you can try and find out what the antidote is. But the patient just did not tell us. So in the end, we had to go for this like super antidote, which has the antidotes for like 15,000 species, and a 10 ml vial of that costs like £15,000 because it's so hard to produce that. So because in the NHS we have to do it, so we just gave him that. In the end, he survived, but he went down the mental health route, etc. So sometimes we will never find out what the antidote was. I think down the line, he eventually had some talking therapy and he told us that it was scorpion. But we had to go for that one because that's our last option. If we don't know what's happening, when I say someone's life, you just have to go for it.
Definitely. Thank you very much. Yeah, it's an interesting point from Sarah as well. I imagine some types of poisoning, like when people are saying inject yourself with antiseptic and things like that, all of these alternative dark internet treatments for COVID and things like that probably increase the instances of poisoning as well, I'd imagine.
Yeah, 100%, Sarah. Even with when Trump had his Twitter account before it was taken away, so he used to like post some really erratic stuff about hydroxychloroquine and allopurinol or some random medications which had like absolutely no evidence behind it. So people were just buying these like anti-malarial tablets, anti-parasite tablets, and they were taking it, right? And thinking that it would help. But actually, ultimately, it just did not. And I think there was some stuff in other countries as well, saying that injecting bleach would be helpful. I think Trump dabbled in that as well at some point. So people have done that, but you should always think about why is someone doing that, right? So doing that because of COVID protection doesn't mean they want to end their life. It's the opposite. It means they want to protect themselves. So it's just misinformation that's got them down the wrong way. So when you're as doctors, right, the meaning of doctor in Latin is teacher. So you are responsible for your own patient's education and teaching. So you have to spend some time, of course, explaining the medical things, but also to keep it simple and give them the background and teach them in a way that they understand. Okay, hope that helps, guys.
Thanks, Dr. Melvin. Well, it's always nice to have a bit of a context to what we're learning as well, a bit of conversation. It's nice when people come in with their own stories and people they have dealt with and things they've seen as well. So where time's getting on a little bit, so I'll just crack on with the presentation. So you can see the slides again, yeah? Yeah, cool. So yeah, poison basically is just defined as any substance which can cause harm to the body in the wrong quantities, okay? So it could be literally anything. And there's 5 ways it can enter the body. They can be swallowed, most common route, so like a kid swallowing one of those washing up tablets. They can be injected, and that's not just through syringes like drug users, it can be injected by creatures as well, like the scorpion used its sting, so it injects the poison that way. It can be instilled, i.e. splashed in the eyes. So you remember that session we had, I think it was the last session where we talked about acid attacks. Even though the acid itself isn't really a poison, it might have toxic effects on the body, particularly if it enters through the eyes, okay? So it can be instilled as well. It can be absorbed through the skin, particularly substances like hydrofluoric acid or organophosphates, particularly the more potent ones. Those are what a lot of nerve agents are based on. You might have heard about Salisbury poisonings, things like that. That would have been absorbed through the skin, because I think one of the victims handled a perfume bottle. She didn't lick it or anything, but it was that potent that it just absorbed through the skin. So that's another way it gets in. And it can be inhaled as well, like carbon monoxide, your fumes, gases, that kind of thing. So whenever we, as responders, first aiders, when we're dealing with a case of poisoning, what's our number one concern above everything else? So someone want to shout out? What do we think?
Your main concern should be making sure the poison doesn't get to other parts of the body.
Yeah, that is a concern. Not quite our number one concern though. Let's see. I'll just open the chat. Think of an acronym that we use quite a lot. What's the first item on that? Begins with D. Danger? Yeah. Particularly important with poisoning, because before we understand what's poisoned them and how it's poisoned them, we could just as easily be influenced as well, particularly in confined spaces. If there's been smoke or something like that, you're vulnerable too. If it's been injected, like drug users, things like that, there could be syringes or needles lying around that could have HEP or anything on them. If there's an attacker with an acid attack, that kind of thing, you have to assess the scene first and check for danger above everything else, as usual with the first aid, but particularly with poisoning as well. So there's so many symptoms with poisoning. They're very, very diverse. So we've only really got time to discuss the generic symptoms, but if they show any of these kinds of symptoms and they have a history of ingesting something, so if they're conscious, they'll tell you about it, or if there's pill packets lying around, empty bottles, containers, that kind of thing, and they have headache or dizziness, sickness, they're finding it difficult to breathe, if they've got mottled skin or cyanosis, or if they're gradually becoming less and less responsive, then you can probably assume they've probably taken something they shouldn't have done. Okay, so if you look out for any of those symptoms, couple it with the history that you do in the secondary survey, and that will probably tell you they've ingested something bad. So with poisoning, again, the first aid before we sort of get them into the ED is fairly limited. It's all about the primary and secondary survey. So what have they taken, how much, and how did they take it? Because that will make the patient handover all the more quicker. So always check for your danger first. Where are the needles? Where is this poison? Is the container closed? Have you got gloves on, mask? Because you need to use PPE as well. And then we just go through the rest of our mnemonic. So we look at the patient. I want to see how responsive they are, first of all, because that will tell me about their brain function. And then we do the signs and symptoms, allergies, and so on. We get that information from them. Then I want to know, can they breathe properly and are they breathing properly? So we do that. Check the breathing, rhythm, speed, volume, and pitch. Then we just go into the C, doctor's ABC. Right, so we look at the circulation. Are they bleeding anywhere? Some poisons, particularly acids, they might be leaking fluids and blood from the site of the wound. Then we do the rest of the checks as well. So pulse, we look at skin color, CRT, capillary refill test. You remember, you pinch your finger, you see how long it takes to go pink again. And your temperature. Your disability, so this is where we do all the rest of the checks, which is why I showed you my observations a bit earlier. So I do the Perla test, so flash the light in the eyes, color, sensation, and movement. So have they got any paresthesia, pins and needles, weird sensations, goosebumps, anything like that that's not normal? And finally, BM, which is blood sugar, glucose, because if somebody's poisoned, their symptoms might be masking something else like low blood sugar or hypoglycemia that share very similar symptoms. So we look at their blood sugar as well. And finally, exposure. So we expose the site. Are there any track marks for injection sites? Is there skin or injured in it or broken in any way? So the last thing we do once we've done all of our checks is basically get them to hospital as soon as we can. So that's really the only first aid we can do. Do all of the checks you can on this patient, get as good a picture as you can, and get them to hospital as quick as you can. All right. So if somebody's become poisoned, they've taken something in the house they shouldn't have done, they can display all kinds of symptoms. They might be fine, but never make an assumption and always take them to the hospital. All right. So do doctor's ABC to the best of your knowledge as we've gone through, and get an ambulance down there as quick as you can. If they do puke, try and keep a sample of it as well. So get a sandwich bag or try and get a bit of tissue, put it in a bag or something, because the ED, the hospital, can do tests on that. They can do all sorts of chromatography and spectrometry. They can find out what's actually been taken. And they have hotlines to the manufacturers of a lot of these chemicals, so they can get the right antidote straight away. So if they vomit, try and keep a sample of it. But danger, danger, danger. If you don't feel safe going into that scene, stay well out of it. Don't worry about the patient. You're more important, all right? And particularly bystanders as well. Because the order of assessing danger is yourself first, bystanders, then the patient, okay? Because they're already a casualty and you don't want to be as well. Okay. How's that? The whistle stop tour to poisoning. I mean, I could talk about poisoning for hours. We could go into different types of drugs and their symptoms and things like that. So it's literally day one introduction, but hopefully that's given you a bit of context. So has anybody got any questions they want to ask? Oops. I can't see the chat. Have we got any questions on the chat? Does anyone want to shout out any questions? No. Cool. Well, we can come back to questions at the end as well. So to wrap up our last part of the session, we're going to be talking about diabetes and diabetic emergencies. So does anybody, well, you don't have to say, but is anybody here diabetic or knows somebody who's diabetic? Does anyone, nobody? Yeah, Iris, are you comfortable talking about it? Is it yourself or someone you know?
It's just somebody I know.
Yeah. Do they manage it with medications, or are they usually quite mild?
Yeah, they use insulin and obviously sugar on hand.
Brilliant. Yeah, diabetes is quite common. My gran's got diabetes, and it's becoming more and more common as well, particularly with the type 2 diabetes, which is usually acquired rather than genetic. People eat a lot more, people are living more sedentary lifestyles, and diabetes is becoming a lot more of a problem, okay? So at some point, you'll probably know somebody or even have to treat somebody in a diabetic emergency. So because we're all future doctors here, we'll have a little bit of a discussion about how diabetes actually works, and then we'll look at the first aid for it. Now, I'm hoping this diagram works because I spent ages making the shapes for this. Right. So in a normal person, we get our energy from food, okay? Now, these foods contain complex carbohydrates, quite complex chemicals, but they contain a lot of locked up energy. Now, when you eat, you digest it. That breaks down all the complex carbs into glucose. Now, glucose itself can enter blood vessels, but they can't enter cells, okay? In order to enter cells, they need to be bound to insulin. And you have your pancreas, lovely little organ, and that releases a lot of chemical insulin, and all that does is it binds to the glucose, and that enables it to enter cells, okay? So this glucose insulin complex, there's a few different things that can happen to it depending on what the person's blood sugar is doing at the time. So the first route is it goes to the cells. It powers cellular reactions, it forms ATP, it does all sorts of things. Eventually, there'll be too much glucose in the system, doesn't need any more, at which point it goes to the liver and it gets stored as a substance called glycogen, okay? If the glucose in the blood drops again, there's a release of glucagon, which is again released by the pancreas, and that kicks more glucose into the system, and it's that whole cycle, okay? So it's kind of like a constantly self-regulating process. However, in diabetes, or to give it its full name, diabetes mellitus, that part of the process is broken. Now, some people either can't produce insulin, or the insulin they do produce is either not enough or it's not effective. So in a sense, they've got no way of regulating this process effectively. All right. So there's two types of diabetes. There's type 1, and these people are, they don't produce the insulin, okay? Its full name, insulin-dependent diabetes mellitus. Basically, these are the people that have to take their insulin, okay? They're artificially introducing the insulin to their system to help regulate their blood sugar. Usually found in children, but it can occur later in life as well. And then you have type 2, which is what I mentioned a little while ago, where people don't produce enough insulin, or it's not effective. And that's not always, but sometimes the result of the sedentary lifestyle, you know, sitting around, not exercising enough, and so on. So it's type 1 and type 2. the ones where they do have to take insulin are the type 1s. The type 2 usually manage it with non-insulin medications, so things that can kickstart the pancreas to work on its own rather than introducing the insulin to the system. Okay. Now, the problems we have with diabetes in itself is a condition, not a problem. But if diabetes causes the blood sugar to go too high or too low, that's when we have to become involved. So if the blood sugar goes too low, that's a condition called hypoglycemia, much like hypothermia, just means low, or too high, hyperglycemia. Yeah. So this is where we have to be able to monitor their blood glucose properly, and we have to do the primary and secondary survey. So doctors ABC, and then we can decide what our priorities are after that. All right. Now, the normal glucose range is measured in millimoles per litre of blood. It's about 3 to 5.6. You can go slightly higher than that. That's not a problem. I mean, particularly after you've eaten a big meal, it's probably going to be a bit higher than that as well. But when we do the blood glucose testing, that tells us a lot, you see, which is why we carry around the blood glucose tests. And for your interest, I'll do a blood glucose test on myself so you can see how it's done, because it's only the best for you guys. So, like I say, we've got what's called a lancet, which is basically a needle that goes into the finger. It's not like a jab in, hurt one. It's literally just a little click, just enough to get a small drop of blood, and then we put it on the test strip, and the machine tells us what our blood's doing. So let's see if I can make this work. There's always a risk on camera that it won't work and it'll be a disaster, but we'll give it a go. Let me just get a test strip out. Right. So when we do blood glucose testing, we try and do it not on the pad of the finger. We do it on the edge because it's less likely to hurt. So literally all you do is you put the lancet in the finger, ow, and press it. There's the world's smallest amount of blood coming through. It's probably too small for the test strip. Probably can't see that. And then you scoop it onto the test strip like that. Get a little bit on there. I'll try and squeeze out a bit more. There we are. And then I get my blood glucose monitor. Insert the test strip. And here's a moment of truth where we find out what my blood sugar is. E6, error. Hang on a sec. It's because I haven't bled enough onto it. Right. They're quite bloodthirsty strips, these ones, sometimes. Right, let me just try and get out a bit more. There we are. Bleeding properly now. And then, hopefully, just give it a second to process. That's not working, but it will give you a display. This one is just basically because there's probably something wrong with the strip. But it will give us a readout, just a simple number in millimoles per litre, and that tells us what their blood glucose is doing. All right. So if I encountered a patient and their BM was quite low, at this point, it'll be suspected hypoglycemia, particularly if they have a history of diabetes as well. If it's quite high, I mean, quite an alarmingly high figure, then we might need to intervene. But like I say, if they've just eaten dinner or something, that's not usually a cause for concern because your blood sugar naturally fluctuates throughout the day. But if they do have any of these symptoms, so they've got an excessive thirst, they keep bleeding, they urinate quite a lot, they're quite hungry, they get angry. You might have heard the term hangry. We all get that from time to time. But if somebody's had a change of behavior, they get a bit pale, they're not really with it, then you might want to suspect hypoglycemia at this point. And yeah, that's just some of the symptoms. But like I say, usually they've got a history of diabetes, so you can effectively deal with it. So the first aid for it, if they have any kind of medication that they use to manage it, help them to take that straight away because that will be the most effective thing that they can take. If their blood sugar is quite low and they suspect it's quite low, and you have access to sweets, chocolate, biscuits, fizzy drinks, anything like that, get them to take, probably the best one is a chocolate bar and maybe a sweet drink, something like orange juice or a Coke. Don't give them diet drinks like Diet Coke or whatever, because it's aspartame rather than sugar, and that's not good enough. So get them something sweet to drink, get them some biscuits or a chocolate, and get them to take that. Obviously, if they're starting to lose consciousness, it's probably best not to feed them stuff, but keep an eye on them. Sit them down in case they collapse, and just watch them for about 10 minutes. If they've got a blood glucose test, because a lot of them usually carry them, do another test after about 10 minutes, see if their blood sugar's picked up. Keep an eye on their symptoms, and if it hasn't picked up yet, then just give them some more sugar. All right. You might find they carry a substance called glucogel or glucotabs. That's basically purified glucose, so that's much better. You can use a glucogel, put it in the mouth, much like aspirin, get them to swill it around their mouth a little bit. That should pick it up. If they don't respond to that after the second dosage, or if they start to lose consciousness, or they basically not react in the way that you should, just get them to hospital. On the other end of the scale, hyperglycemia, where the blood sugar is too high, there's not much you can do for that in terms of first aid. Fairly similar symptoms. They might have quite hot, dry skin, quite a bounding pulse. They might also have sweet smelling breath as well. That's usually a giveaway. If they're hyperglycemic, the main treatment is just sit them down, keep an eye on them, and get an ambulance there straight away. But yeah, that's basically it for diabetes. We just help them take their medication. If they've got a blood glucose testing kit, use that. And then just keep an eye on them and get them to hospital if needed. Cool. Does anybody have any questions about that? Well, just finish with the concluding slide, and then we'll have a whole bunch of questions. So thank you very much for attending today. I hope you enjoyed it. We did fit a lot into today, which is why we had to just do brief introductions to a couple of concepts. But you've now seen the vast majority of the kit that I carry on duty. There's some other specialised items that I take with me. Hopefully, if we do a future session, I might be able to give you a tour of the ambulance, but because of lockdown and everything, we can't do that at the moment. But you've seen some of the kit. We've looked at neurological first aid and all of its weird and wonderful conditions. We've talked about poisoning, and we've looked at diabetes as well. So you've covered a lot this week. And in the final session, which will be hopefully next week, we'll just consolidate everything we've done throughout the series so far. So I'll create a scenario, and we'll hopefully incorporate as many of the techniques we learned as possible. Basically, I'm going to be your medic, but I'm going to be useless, and you're going to talk me through what I need to do, because that'll really make us think. Then we're going to round this all off, because it's all very well and good learning this first aid and all these techniques, but what's more important for us and for you guys is how you can use this for medical school applications. I'll give you some of my own reflections, because I started doing this stuff before I applied for medical school, and it honestly gave me so much to talk about in the interviews. It was unreal. So I'll share my reflections, and we can have a bit of a discussion about that. And then we'll have a big old Q&A where you can ask me about some stuff I've dealt with in the past. I'll share some stories, and basically it'll just be a nice conclusion to the series. All right. And yeah, if you've got the time, do your reflective workbooks as well, because it's you might remember everything now, but trust me, after a few weeks, you're probably going to forget a lot of this. But you can look back at your reflective workbook, reread it, and it'll come back to you. It's all about active recall. And as always, any workbook sent in, I will take the time to read and write some useful comments in there as well. Okay, so do take the time to send in the reflective workbooks too. And that is about it. So has anybody got any questions? Over to you. The floor is yours. Normal rate of blood glucose. It's about 3 to 6, 3 to 7 roughly, as long as it's within that range and not too far outside. I'd say the lower range is more important. So if it's lower than 3, just do something to pick up the glucose a little bit. If it's not massively below, then it can be done with biscuits or a bit of glucagon. But yeah, if it's significantly low, then just see if they've got any medications that you can give them. Ways you can get PowerPoints so you can annotate them. Well, you've got the recordings available. If you want specific PowerPoints, I'm sure that can be arranged, or I can do handouts or whatever. But if you send me a message or send me an email about anything you want specifically. Then once I get the time, I'll make a little pack or something up for you, and you can keep that for your notes as well. Any questions? No. Terrific. Well, thank you very much indeed for attending today and for your attention. It's been a lot of information, but I hope you've enjoyed it as much as I have. It's nice seeing how these techniques are working in practice. And before I sort of got involved in all this stuff, you'd watch programs like 24 Hours in A&E and Ambulance and things like that, and you just see all the equipment and how they work on people, and you just think, wait, what are they doing to that person? And you just want to get involved and learn a bit more about it. So I hope by getting all this equipment out and showing you a little bit about how we intervene with these people, it's not only been useful for you, but it's been interesting as well, because it's something that I wish I had access to. And yeah, you can use any of these lessons, not just for the medical school, but you never know where the next emergency is going to be. And chances are it's probably going to be when you're relaxing in your garden, you're off duty and you've got nothing else to do, and someone decides to have a car accident at the end of the road, which happened to me during my A-levels. So the point of that is that you never know when there's going to be an emergency. So even just a basic bit of first aid, you can start helping people straight away. And at the end of the day, that's what we're all in this to do, aren't we? So yeah, we can help people out. Great. Well, enjoy the rest of your evening, afternoon, morning, wherever it is where you are. And yeah, like I say, I'll put announcements on the chat about the next session. And yeah, keep being amazing. Thank you very much, all. Take care.
Thank you so much. Have a wonderful day.
Yeah, see you later.